name's Kevin Cranston. I direct the Bureau of Infectious Disease at the Mass Department of Public Health. I also was the director of the HIV/AIDS Bureau for a number of years, and I'm also at the Department of Public Health. And I pretty much spent my whole life in the AIDS epidemic. I'm old enough to remember the beginning, some of you are, and some of you aren't. Olivia definitely is not old enough. And I'm really looking forward to Olivia, growing up in a world that doesn't have to worry about HIV infection. We're not there yet, but the possibility is there. So, going back to 1981, really friends of mine, I lived in Boston at the time, I still live in Boston. Friends of mine started getting sick, and this is even before we knew AIDS had existed. When the first cases were identified in New York and San Francisco and Los Angeles, this emergent something, we didn't even know it was an infection at that time, started killing people, and then shortly thereafter, we recognized women, injection drug users, people from other parts of the world were acquiring HIV in significant numbers. What scared us so much at the beginning of the epidemic were actually very small numbers, when now we're talking about 34 million people throughout the world living with HIV or AIDS, and well over 25 million people have already died of HIV infection. But the theme of World AIDS Day is getting to zero, because for this year and for the next 3 years, the World Health Organization and the UNAIDS, the Joint Program on AIDS, has declared getting to zero as the theme, because really for the first time, just in the last couple of years, we are recognizing not only can effective treatments, if we can get them to everybody who has HIV, enable people to live essentially normal lifespans. In the early parts of the epidemic, we used to have charts that went up to about age 45 or 50, because very few people lived past the age of 50. Most people with HIV in the early days of the epidemic died within 18 months of their diagnosis, so we experienced it as a terminal diagnosis at that time. Now my chart goes to 70 plus. I have friends and associates and people I know in the field who have been living with HIV for 30 plus years. And they can only do that because we have effective treatments available and a system of care that surrounds people with HIV and AIDS, that enables them to get to the doctor, to get to their medications, to stay on their medications, and all of the other support services. Support from peers who have HIV, transportation, particularly in parts of the state where public transportation is not so readily available. I suspect that may be true, in Webster for folks who are getting their care, say, in another part of the state. But also, some people need nutrition support, housing supports. All of those non-medical support services are also critical so that people can get optimal advantage out of the medications and the medical care that they get from their physicians. But what we've also learned very recently, the number I put out there is 052. It's one of the designations of a study that was published not just in the past 2 years, that showed, it's a study of people where partners, heterosexual partners, where one had HIV and the other partner did not. If the person with HIV is on their medications and got to what's called viral suppression, or a reduction of viral load to a level that current tests can't detect it, the virus is still there, but it's at such a low level, it's unable to replicate fast enough to mutate or cause disease. If the positive person has viral suppression, or is an undetectable viral load, the risk of transmission to the negative partner is almost eliminated. It was reduced 96% in this study. And we believe that if everything were in place, in fact, transmission may not occur at all for individuals in that situation. So this means we have one of those rare moments where doing the humane thing for people with HIV, getting them into care, getting them into the medication and medical support they need, also can transform the course of the epidemic and reduce the incidence or the transmission of HIV to manageable levels. Epidemics need a certain level of transmission to keep themselves going. And I'm here to say Massachusetts may be the first place in the country, arguably the first place in the world, that might actually see a 0 year in the future. In the year 2000, 1,200 people were diagnosed with HIV infection in Massachusetts. In 2010, which is the most complete year that we have data for, 650 people were diagnosed with HIV. It's an almost 50% reduction in transmission. The curve just goes like this. And if you extend that curve far enough out, you get to a 0 point. Now, I'm not saying we've done it. We have a long, long way to go. But deaths are down, transmission is down, people are living longer and healthier lives with HIV infection. And it really means keeping our guard up, keeping young people educated around their sexual lives and their drug use lives. Hopefully not having, not engaging in sexual behavior until they're ready and know how to be responsible about that in the context of a committed relationship, but also helping kids not initiate some of the things we're starting to be worried about in the state is opiate use at an early age. I don't know if you're seeing it here. We're certainly seeing it in Eastern Mass, where pharmaceutical use of things like OxyContin, which then turns into illicit use and sometimes turns into addiction and the use of other opiates like heroin and injectable drug use. We really need to stop another generation of kids from repeating what their older forebears went through. Injection drug users have seen a 75% reduction in new transmissions. We've almost eliminated injection drug use related HIV in the state. I don't want to see it get started again. So I'm very excited to see the presentation, not only of the quilt, but of the artwork of students in Webster schools, because building that awareness, building that knowledge of HIV and how it's transmitted can help a whole nother generation avoid what my generation had to live through and experience. So I'm simply delighted to see the town commit itself to this work and to keep HIV on the front burner. It can feel like HIV has already gone away. It's not in the news nearly as much. We have this sort of annual moment where we talk about it. But in fact, there's never been more people in Massachusetts living with HIV and AIDS than there is today. And there'll be more tomorrow and then more the next day. But if we can keep our guard up, keep our prevention programs going, get everyone with who has HIV tested, this is really critical. You can't get the benefit of treatment unless you're tested and know your status. Helping people speak openly about their experience, their risk, as well as their infection status, and make sure all the support services, medical services are there for people with HIV. I actually do believe that Massachusetts can be the first place in the country, and maybe the first place in the world, to say, we got to 0. And it's really my hope. And that's really my 5 minutes for you. I'm happy to answer any questions or entertain a conversation about folks in the town.
And some of the statistics that you're citing, they are so promising and so hopeful, but they do rely on medical care.
That's right.
As well as this community care.
That is correct.
And that has a cost associated with it. So how successful is Massachusetts in communities of high poverty?
Sure, I'm happy to talk about that. First of all, there's a couple of things that are unique about Massachusetts. We were the first state in the country to expand its Medicaid program to provide coverage to people who have HIV and meet the income requirements. Almost everywhere else in the country, and hopefully this is going to change under the Affordable Care Act, but right now, almost every other state in the country, you need to have an AIDS diagnosis in order to be eligible for Medicaid, even if you meet the income requirements. So if you make 200% of poverty or lower and have HIV, you don't need to have a child, you don't need to have another disabling condition, you become eligible for Medicaid. So that's one of the things we did back in 2001, which I think is responsible for a lot of our care, a lot of the quality of our care. We also have a HIV drug assistance program that not only ensures that people can get their medications, we actually buy health insurance for people who otherwise can't afford it. Or if you can afford health insurance but can't afford your co-payments on your drugs, which can be quite high. Many co-payments on drugs are $45 a piece, and a lot of people with HIV are on 3, 4, 5 different medications. That couple of $100 can make the difference between being in care or not. Our program will pay the cost of the drugs or the insurance or the co-payments, so that regardless of your income status, even if you make more than the Medicaid cutoff, we're able to ensure access. So if you look at our data, not only are the numbers down overall, but amongst Black, white, and Latino populations, they're all going down at the same rate. And populations in all parts of the state, the geography, everyone seems to be getting the same benefit from the programs and the medications. So while I know there are people struggling with a lot of things, housing, and homelessness, they may be struggling with addiction or mental illness. These are more common features of people recently diagnosed with HIV. We need to make sure all those programs are also in place so that people can get the benefit of our program. For some of these folks, HIV is the least of their problems. HIV is the piece of their lives that's under control. But we have to make sure we don't put barriers in the way of the great services and programs that are available.
Sure. What about this at-home test for HIV that was recently read?
Sure.
It says swab.
That's correct. What's different about that, there have been at-home test kits available before, but those were finger stick tests that you mailed the blood spot in and had to wait for a response. This one you do yourself. It's based on a technology that we've been using almost for 10 years in the United States. It's a rapid test. It's called the OraQuick rapid test. It's one of many rapid tests that are available. And when you do it, when you use it, say, in a clinic or in a test site, you get your results back in about 20 minutes. This is the first company to turn their sort of clinic-based kit into a home test kit. It's the same technology, however. It's very well utilized. We buy a lot of those kits. We've been using it for years in Massachusetts. And I believe for some people who just won't make an appointment with a physician or won't go into a test site, who really need an absolutely anonymous test in order to start the process, I think it creates an opportunity. It costs about $40, so that may be a barrier for some people. We're actually looking, we're negotiating with the company right now to see if maybe we can get some special public health pricing. I believe there's, for some communities that won't test on their own, we could theoretically make vouchers available where folks could access the test. There are some concerns about people testing alone and finding out they're positive without support. The company has a really good phone-in support system, and we're looking to link it with some of our local resources like the AIDS Action Committee's hotline to also provide some follow-up information. So I think it's just another tool in the overall arsenal, you know, against HIV. And so I welcome the approval of the test. I'm curious, is anyone out with HIV in Webster? Is anyone? Are there any publicly identified people with HIV in the town?
I don't think so. I don't think so.
I'm sure individuals know individuals, but you know, I didn't look up your numbers before I came out here. I'm not aware that you had very many cases over the course, you know, of the epidemic, but I could check that out for you. I was just curious. Please.
I have a quick question. Now, you had mentioned how your cases have really dropped significantly over the past 10 years or so. Do you have a case manager that oversees the population, or is the population more or less seen in clinics or doctor's offices, things like that?
Sure.
That because they're so, for the resources, for the needs.
Yeah, I mean, while there's a smaller number of new cases, we have at least 18,000 people. That's how many people have been diagnosed and reported currently living with HIV. We estimate that could be as many as 25 to 28,000 people if everyone knew their status, but we don't know that exactly. So as important and as central as medical care is, we do fund community-based organizations in addition to clinical services that provide support. Case management has always been a piece of our HIV service system. A lot of it is what we call social case management, helping people manage the rest of their lives. And increasingly, we're funding medical case management, because people not only are seeing, say, an infectious disease doctor or you know, an immune specialist, but they may have other issues. A lot of people with HIV have other medical issues, so they may have diabetes, for example, or increasingly people with HIV are older. About a third of people with HIV are over the age of 50. So they may have other medical issues. So coordinating all that care is something we also support. It's usually a nurse case manager that sort of keeps all the physicians communicating with one another, and then working with community-based services to make sure those are intact as well. It does no good for people to have a bottle of medications if their landlord's about to evict them because of non-payment. So our job is to keep that as intact as possible. We can only do so much fighting poverty directly out of an infectious disease bureau. So we partner with elder services, we partner with housing organizations, educational organizations, vocational services, because it's really a lot of our jobs to make sure folks have all the services they need.
Thank you.
thanks a lot for having me. I'm happy to hang out a little bit.
Thank you very much.